So next we'll go over some embryology to better understand how this anomaly occurs. So in normal development, the ectodermal cells give rise to the neural folds, and the neural folds develop, then fuse, which creates the neural tube. This typically occurs during the third embryonic week. The neural tube then gives rise to prosencephalon, mesencephalon, and rhomboencephalon, which then give rise to different portions of the brain. So again, the neural tube develops into multiple vesicles. The prosencephalon, which is the forebrain, encompasses the diencephalon, which becomes the retina, thalami, and hypothalamus, and the telencephalon, which becomes the cerebral hemispheres. The mesencephalon will eventually differentiate into the midbrain and rhomboencephalon, which then forms the pons, cerebellum, and medulla. Today we'll be focusing on specifically the prosencephalon, as this is where the error occurs, which then leads to holoprocencephaly. So here is a nice graphic image, which again is depicting the different vesicles, known as the telencephalon, diencephalon. So you can see this nicely here. And then these vesicles either elongate or give rise to more vesicles, continuing the neural tube growth. On the right, you can see a scan at 10 weeks demonstrating this anatomy. And remember, HPE occurs when the prosencephalon, which is up in here, fails to divide into separate lobes. So here is a quick 1-minute clip that has a really great visual of this step. Worked last night. I don't want your practice.
It's the sound isn't connected to the website thing, that's why.
So right now you can see the prosencephalon is up here, and this is first showing the normal embryonic changes. So here you can see that they're separating as they should. These two little notches turn into the optic nerve. And you can see here, this is the cleavage where the two cerebral hemispheres develop. And this is normal.
That's not exactly like
The next one will show you abnormal. So again, we continue to focus right here, the prosencephalon. You can see that it's not dividing like it should. So you're not seeing the two different cerebral hemispheres here. And this is showing you a lobar. So you can see it's one, it hasn't divided, and you have this space here. Sorry about that. I thought the audio. So this malformation is thought to occur in 1 out of 250 embryos. However, the majority of these do resolve miscarriages. And then the anomaly is thought to occur in 1 in 10,000 to 16,000 live births. This is the most common forebrain malformation. So there are 3 different types of holoprocencephaly, and I'll review these types in order of severity. Alobar holoprocencephaly is the most severe, and it does occur approximately 2/3 of the time. This is due to the complete or nearly complete lack of separation of the cerebral hemispheres. That was what we were just seeing. That is what we just watched in the video. Less severe is semilobar holoprocencephaly, which is due to the partial cleavage of the prosencephalon. and least severe is lobar holoprocencephaly. And in this case, the interhemispheric fissure is present along the entire midline, and there is some differentiation of the cerebral hemispheres. So here you can see the different types and the degree of severity from a normal brain to a lobar. So again, this is normal, and then all the way to the most severe is abnormal and alobar. So the etiology of holoprosencephaly is multifactorial, and while some cases are sporadic, there have been associations with chromosomal abnormalities, single gene disorders, as well as teratogens such as and poorly controlled diabetes. So next, I'll go over the ultrasound findings. And holoprosencephaly can be diagnosed with ultrasound in the first and second trimester. And the majority of cases that are diagnosed in the first trimester are typically a lobar because it is the most severe. So failure to identify the butterfly sign, which is right here, and first trimester evaluation is associated with a 100% detection rate. So these are both first trimester ultrasounds. The left is normal. You can see the choroid plexus, which looks like a butterfly. This is called the butterfly sign. This confirms that there are two separate cerebral hemispheres. On the right is an abnormal finding, which is a lobar HPE. You can see this entire area is fused. You do not see the separation. And you see this single space, which then becomes one ventricle. Detection of lobar HPE, which is more subtle, does rely on the appearance of the CSP, and this is typically diagnosed later in pregnancy in the second and third trimester. So now we'll discuss the ultrasound findings of each. So in alobar HPE, which is again the most severe, the findings are as follows. There is an absent or at least abnormal CSP, a single ventricular cavity with absent midline structure. So these include the interhemispheric fissure, the falx cerebri, and the corpus callosum. The thalami appear fused, and a dorsal cyst is commonly present. Other associated anomalies with alobar in particular is facial dysmorphism, and these can, vary. The facial profile, orbits, nose, and lips can be abnormal. Sometimes you will see cyclopia, which is depicted here in this image. And there can also be proboscis, which is this tubular structure that is found above the eye. Hypotelorism is also present, which is the when the eyes are abnormally close together. Some cases also have a midline cleft lip and palate. And while these are common, it is important to note that sometimes the face can appear completely normal. So here's an example of the varying degrees of associated facial anomalies. So here you can see the cyclopia all the way to a patient who's very mild with no facial abnormalities. So here's a comparison of a normal versus an abnormal axial view ultrasound in alobar HPE. So here is the normal view. You can see the falx, you can see the thalamus. They are not fused. And on the right is an abnormal ultrasound. So here you can see that the thalami, which is here, this is fused. There is no falx that we could see here. And then there is this monoventricular cavity. So you're just seeing this one ventricle here. And then to review some more ultrasound pictures, this one on the left is a coronal view. This is again demonstrating absent midline structures, which you typically would see here. Again, a single ventricle. And on the right is an axial view. You can see that the thalami are fused here. And then the proboscis, which was that tubular structure above the eye that we saw in the previous picture. So here on the left, you can see a gross image as well as an ultrasound. Here's typically where you would see this dorsal cyst, which is depicted here in this image. The dorsal cyst is just this space where it is filled with fluid in patients with the severe kind of holoprocencephaly. So next, MRI findings. This can be helpful in determining what kind of holoprosencephaly this fetus may have. So these are two images that are in the coronal view. Both patients have alobar holoprosencephaly. On the left is a patient or a fetus that is 22 weeks, and on the right is 21 weeks. So in both images, you can see a single ventricular cavity. Here you can see thalami, and there is no interhemispheric fissure, which you would typically see somewhere up here. So next we will review semilobar holoprosencephaly. And some of these findings are comparable with the alobar type. So here, the anterior horns of the lateral ventricles are absent, but the posterior horns of the lateral ventricles are well developed. The CSP is absent or abnormal, and the thalami is either completely or partially fused. Microcephaly is also common, and facial anomalies can also be found. However, they are typically more mild when compared to patients with alobar holoprosencephaly. So here are some ultrasound images with a fetus with semilobar holoprosencephaly. So on the left is a coronal view of a 19-week fetus. You do not see a CSP. You can see a partial fusion of the thalami, and you can see they call it a rudimentary interhemispheric fissure here. On the right is another coronal view, and here you can see that there is a definitive interhemispheric fissure here. There is also a partially fused thalami here, and then here is where you see this monoventricle. Couple more images here. So these are pictures of the same fetus. This was again at an anatomy ultrasound. This view is a little bit oblique, but there is an absent CSP. You can see the frontal lobes are fused. They are not separated, but you can see that the occipital lobes are separated posteriorly. And you can see this monoventricular thing. Again, this is just another angle. The parietal lobes here are separate. There's a normal cerebellum, normal cisterna magna, and then here there is partial fusion of thalami.
Try to memorize that picture on the left because that's pretty pathognomonic, and you can see your career. If somebody comes in, with a picture from a sonographer.
So here on the left is an MRI. Again, you can see this monoventricle, part of the fissure, and the partially fused here. And then this is this I thought was really cool. So this is obviously a gross image of an autopsy, and you can see this monoventricular ventricle as well. Spheric fissure here, and this partially fused thalami. And then last is lobar holoprosencephaly. So in the lobar type, the anterior horns of the lateral ventricles are fused. There is an absent CSP. In the midline, the interhemispheric fissures and faults are typically present. The corpus callosum is also present. However, it's not always completely developed. The posterior horns are well developed. And as a result of the fused anterior horns, the anterior cerebral artery is pushed externally and will run on the surface of the brain rather than in the interhemispheric fissure. And they call this the snake under the skull sign. And this is an ultrasound image of that. So here are some ultrasound images of lobar holoprosencephaly. On the left is a normal ultrasound. You can see a CSP here, a normal thalamus that is not fused. And then remember, lobar holoprosencephaly is the least severe, so it can be harder to diagnose because the findings are not as severe as alobar. You can see here that the thalami is normal, but we're not seeing a CSP, which we would typically see here. So the absent or abnormal CSP is the clue. Here are some more ultrasound images of lobar holoprosencephaly. So the top two images are from a fetus that was 22 weeks. And then later in the pregnancy, this fetus was scanned again, and this is a 32-week ultrasound. So here you can see there is an interhemispheric fissure. There is no CSP visualized. The frontal lobe is fused here, and there is partial thalamic fusion as well. Which is here. So here are the MRI findings. This is a fetus at 26 weeks. So here on the left is the axial view. And this red arrow demonstrates partial anterior fusion. And then on the right in the coronal view, this red arrow is also demonstrating frontal basal fusion here. So there are also other variations, such as the middle interhemispheric variant, or MIHV. This is an intermediate condition which does have components of both alobar and lobar holoprosencephaly. So in this case, which is depicted here, the frontal horns are more developed than in alobar holoprosencephaly, but the posterior horns are poorly developed, and it appears as a single ventricular cavity. The CSP is absent, the thalami are incompletely separated, and posteriorly the interhemispheric fissure and faults are absent. So the different associated anomalies are as follows. These fetuses can also have craniofacial abnormalities such as cleft lip and palate. Again, the severity is worse in alobar holoprosencephaly. CNS anomalies such as neural tube defect and Dandy-Walker. Malformation can also be found in these cases. Microcephaly, as well as extracranial malformations such as renal cysts, abdominal wall defects, cardiovascular malformation, clubfoot, myelomeningocele, and intestinal abnormalities are also found in these cases. So in terms of the differential diagnosis, in alobar holoprosencephaly, where there is a single ventricular cavity and absent midline structures, the main differential is hydranencephaly. So alobar holoprosencephaly has the large ventricular cavity and has a similar appearance to that of hydranencephaly. However, in this anomaly, some midline structures are present. So here, these are pictures of hydranencephaly, and you can see the midline structures here, which we do not see with alobar holoprosencephaly. Now for lobar holoprosencephaly,
Typically the faults, especially when you have
Right.
that degree, is like that midline fault and the anterior, like that's not gonna be present for alobar or semi even.
So for lobar holoprosencephaly, this must be distinguished from other types of ventricular megaly that are at times associated with this secondary disruption of the CSP. This is particularly frequent with cases of spina bifida and severe obstructive hydrocephalus. Distinction between agenesis of the CSP and lobar holoprosencephaly is one of the greatest challenges. Demonstration of normal ventricles to mild ventricular megaly, a well-formed corpus callosum, and well-developed interhemispheric fissure with anterior separation of frontal horns favors the diagnosis of agenesis of the CSP. Absent CSP absent flexi can be absent or found as part of the optic dysplasia. And in this case, the frontal horns are well separated, and the corpus callosum and pericolossal arteries are present. So next we'll discuss some genetics. So prosencephalic development encompasses the 3 sequential and overlapping series of events that include formation, cleavage, and midline development. This process is governed by signaling centers that generate different proteins that express either ventrally or dorsally in the neural tube. When a patient is diagnosed with HPE, diagnostic testing as well as chromosomal microarray should be offered, as well as a formal genetics consult. So 20 different genes have been associated with holoprosencephaly, but there are really 4 that are primarily responsible. These 4 genes that are listed here are also inherited in an autosomal dominant manner. And most of these genes have a ventralizing effect, and only few have a dorsalizing effect. There are also more than 25 syndromes in which HPE is found, and these account for about 18 to 25% of the holoprosencephaly cases. While this is rare, the most common association is found in Smith-Lemli-Opitz syndrome. This is a condition in which there's an inborn error of cholesterol synthesis, and 5% of fetuses with this syndrome have holoprosencephaly. So there's also significant variability in gene expression. Some individuals that carry this autosomal dominant gene may have a disorder as a result of de novo pathogenic change. So you can see there's 3 different genes listed here. And all of these do have some chance of a de novo pathogenic change. So oligogenic inheritance, which is the involvement of more than one gene, may account for some cases of incomplete penetrance and variable expressivity. Holoprosencephaly can result from an interaction between both genetic programming as well as environmental influences during the periconceptional period and the first few weeks of pregnancy. So maternal diabetes, hypercholesterolemia, alcohol consumption, as well as different dietary pollutants. So non-syndromic single gene mutations do account for about 1/3 of holoprosencephaly cases. Whole exome sequencing is a promising tool, and Solomon et al. Did report a diagnostic yield of 22% in 94 cases of holoprosencephaly, but of course these studies are currently still limited. So about 50% of cases are due to aneuploidy or structural chromosomal abnormalities. The majority are associated with trisomy 13, but triploidy and trisomy 18 also occur. And 14 of these cases are due to pathogenic variants that are identified through chromosomal. So in terms of the pregnancy and delivery management, A lobar especially can be a lethal anomaly. This is a major fetal anomaly, so termination should always be offered. If a patient does desire continuing the pregnancy, they should undergo a genetics evaluation, fetal echocardiogram, as well as consult with pediatric neurology, neurosurgery, and neonatology. Delivery at a tertiary care center where the appropriate specialists are present is recommended. And in terms of mode of delivery, the delivery is typically due to routine OB condition or indications and should be individualized based on severity of brain or facial abnormalities. In alobar holoprosencephaly, if macrocephaly or severe hydrocephaly is present, you can consider performing a cephalocentesis to assist with achieving a vaginal birth given the poor prognosis of the infant. And I did see one case of this in my residency.
Is one of the most traumatic births I've ever been to myself. As a fellow, I assisted in one, and I don't know what was your experience, but
I was there for the cephalocentesis, and then after I think.
and how was that done?
So he did it abdominally. I'm sure he did it abdominally.
Like prior to delivery?
Prior to delivery, yeah.
Oh.
And then
Aspirated
baby-
fluid with
It's
a
like an amniocentesis where you just have to apply more force to pierce the skull.
Do you go
And then the
like?
baby-
No, I was gonna say, how
Like, do you do
go
one?
in?
I mean, I guess there's no wind up
There's no
fontanelle,
canal.
so you just put it right in
You
there.
just
one.
put it right through.
No, but I mean, getting you, if I have to find a fontanelle, right? Like you get, you can pierce through.
Push through hard.
Probably in
Yeah.
between the sutures, right?
She just,
No, she's saying, well, that's what
I
I.
push as hard as I could.
Yeah.
And then after
Maybe
the
one,
baby.
Amanda?
I did one.
Yeah,
We were here, right?
No.
Yeah.
of course. In the jungle.
I mean, the one we did here was vaginally, actually. She had
She
dilated.
came in
Ah,
labor
beginning of labor,
with
and-
massive head.
I mean, you could see kind of, white matter, and fluid and stuff coming through, then the things collapse, the bones, there's still no fuse, collapse, or you're afraid that they're gonna injure the vaginal canal as they come through. It was really And just thinking of what you're doing, even if there's a lethal anomaly, was.
I use the thicker needle, the needle they use for epidurals. In Colombia, different. They're very thick.
Oh, the needle, that's right, if you use a spinal needle.
So the spinal needle is the LP needle that engages, but the epidural needle is called a Dewey needle.
Oh.
Different, it's very thick. So I use that one. So we had two cases. One came with minimal prenatal, like no ultrasounds, and the head was big. So she was transferred because of macrosomia, but in fact it was anencephalocele. And the other one was breached, getting the liver, and it was a mess. Horrible, horrible case. So another
Is a lobar lethal?
it can be done.
They can live for.
They can live a little bit.
They can live.
Okay.
80% to years.
Yeah.
Yeah, I don't know. I don't know here.
Lobar I know is not.
Not-
lethal and-
Have some stuff.
Yeah.
20% is what.
Legally, ethically speaking, can you do
By
one?
80%. By one.
This is,
Here, I was in New Jersey.
yeah, I don't know.
If that's what they're saying, yeah,
The ethics and the.
I don't think it would be legal here.
Because it will cause death.
It'll cause
And
death,
that's
I know.
what
In
this
New
is
Jersey,
like.
it's different.
You can be accused of an illegal termination.
Yeah, New Jersey doesn't have the gestational age limit, but in PA, we're just saying in PA, you couldn't do that.
So I actually have some information regarding the prognosis. I would.
Yeah, thank you,
I was
yeah.
talking about that. So the overall prognosis for the neonate does depend on the severity of holoprosencephaly, the presence of craniofacial malformation, the presence or absence of chromosomal or other syndromes. And again, a lobar is considered a lethal malformation, at least from what I read. So among a group of children with isolated non-syndromic holoprosencephaly, in the group with alobar holoprosencephaly, they were the ones that did survive were unable to sit or speak. 50% had a mortality rate at 5 months of age, and 30% lived beyond 1. In those with semilobar and lobar holoprosencephaly, more than 50% were alive at age 1. In those with lobar holoprosencephaly, 50% could walk with assistance. They had mild hand function and were able to speak a few words. Hydrocephaly is a common problem, particularly in those with a dorsal cyst, and those that do survive commonly have seizures as well as cerebral palsy. Other problems include difficulty swallowing, poor gastric emptying, different GI dysfunction, as well as endocrine abnormalities. So in terms of diagnostic clue, a lack of CSP or abnormal CSP is something that should trigger this diagnosis. Remember, CSP is an indirect assessment of the surrounding brain structures. So in summary, HPE is a severe brain malformation. Alobar is the most common and the most severe type and can be diagnosed early in the first trimester using ultrasound. The rate of stillbirth is very high, and in survivors, long-term outcome is poor and depends on the type and severity of pathology. That is it.
Just to go back to the CSP point, because obviously a lobar holopresence, that's not like a diagnosis you're gonna miss, but for a lobar, that's why if you have an absent CSP, that is a reflection of the development of the anterior portion of the brain, right? So so you can have things with midline abnormalities, like lobar holoprosencephaly, think about the optic nerves, think about the face, because if something is wrong that your CSP isn't present, so that space has collapsed, you want to think about what the other things that are developing around it. So it's important to look at orbit, spacing of the orbits. You want to make sure you see lenses in both eyes. You want to look at the profile, so you're seeing the nose, evaluating obviously for other things like that, and clefting also. So that's where your CSP is really an important landmark, and also you can look at the artery as well, because you can see if there's sort of an abnormal path of the callosal artery, which you might see it, so you're like, okay, there's a corpus callosum, you don't know if it's partial or not, and then you, again, if it's in an abnormal path like you would illustrate it, again, that's illustrating an abnormal development of the front part of the brain, so. And I think that also highlights why in and of itself, it's not like functionally important, right? Like as you get to term and deliver, like this is a space that will go away. So the CSP isn't what's important. It's that if it's not there, that means something else is going on.
If you try to talk to an adult neurologist about the CSP,
Yeah,
they'll
they'll
be
be
there, they'll be like, what are you talking about? Right.
It's not, that space obliterates.
It's the
Association.
associations, correct.
I haven't seen one yet in fellowship. but-
You will.
Yeah. We've had so many anencephalies, I feel like.
Anencephalies, yes, yeah.
Yeah.
For sure. Now there'll be one this morning. Who will text me?
I know.
And be like, can you come down?
It's definitely one of those first trimester diagnoses, and I will say I've never seen someone continue it. And I think here we have a pretty high termination rate for.
I
at
saw
least
somebody
one of these.
continue in Virginia with an A-lobar that had trisomy 13.
Oh, wow.
Yeah, proboscis, hypothyroidism, and died very shortly after birth.
There's a GYN oncologist at Virtua whose son has lobar.
Oh, yeah.
Continued, yeah, she continued.
Like diagnosed in pregnancy.
Yes.
and-
Yeah. But that's also there's such a degree of a
Right.
difference in severity after
I mean,
when
it
in
is
lobar.
No.
No.
Oh, like feeding difficulty.
Yeah.
But yeah, she continued on with the pregnancy.
Just
Dr.
the
Corolla.
time. Yeah, okay.
Dr. Corolla, do you want to tell us about NICU?
We have
I'm in no rush, guys. If you have
We're
continued.
ready.
Yeah, 'cause that actually
You can
looks
go ahead, Dave.
Okay, all right. Sorry for jumping on after. I keep forgetting that we switched it up. So,
it's okay.
just a comment, Sonia. That was great. For those babies, we can manage their care after birth here at Jefferson. If they do need subspecialty involvement that is more than we can provide, we can always transfer them. There's nothing that should impede them being able to be managed immediately following delivery at Jeff. So we have baby Bakeshka. This is a 22 and 3 week baby that's now 30 days old. This was a vaginal delivery with preterm labor. Mom did receive a full course of beta mag and several doses of penicillin. Baby was intubated in the DR and has been mechanically ventilated until last night, was able to extubate to non-invasive positive pressure ventilation after a course of steroids. Has been doing well from a cardiovascular standpoint, does have a PDA that we're monitoring, is on full volume enteral feeds now, which is great, and has a bit of a cholestasis, which we see pretty frequently in babies that were on TPN for a bit. I don't see any concerns outside of that right now. And then unfortunately, this little baby did have a severe IVH, does have a grade 4 on the it's buried here. Where is it? It's on the right and does have some compression and midline shift. So a really pretty significant hemorrhage in the first couple of days after their birth. So we'll be following that closely, and we'll be following with neurosurgeon neurology. Just in case it comes up, the baby did have some. When we place umbilical arterial catheters, sometimes it impacts the arterial flow to the distal legs, and we get sometimes ischemia of the toes. So this little one had the majority of the toes were very ischemic for a bit. Luckily, reperfused all except the very tip of the left great toe. So if mom mentions anything, just so you guys are aware, they might lose some skin, maybe even a portion of that digit eventually, but otherwise looking okay. And that's that little one. So still has a long course left, but we're able to extubate, which is great. So moving in the right direction. Then we have baby Coit. This is a 29 and 0 at birth that is now 45 days old. This is a C-section for maternal preeclampsia, thrombocytopenia. Just got 1 dose of beta prior to delivery. This baby was mechanically ventilated, but has now weaned down to 2 liters nasal cannula, was on room air for about a day, and then just showed that still needed some oxygen. is on some diuretics to help with the lung disease, is on full volume feeds, and did have a course of antibiotics for an MSSA bacteremia that has now cleared. That was back in December. This little one has bilateral grade 2 IVH, so not as severe, and then is on some Synthroid for hypothyroidism that is probably just related to the prematurity and illness, degree of illness, but we'll be following that closely. Next, we have baby Heart. So this is a little 24-day-old that's now, or sorry, 24-week and 3-day-old that is now 2 days old. This was a mom that was transferred over from New Jersey with help worsening preeclampsia and so delivered by C-section. Just received 1 beta methazone a couple hours prior to delivery. And there was meconium fluid at the time of delivery. Baby's APGARs were 3, 6, and 9, was intubated in the delivery room, also under general anesthesia. So this baby came out with very little respiratory effort. I think because of mom's thrombocytopenia, they couldn't do neuraxial anesthesia. The baby's been on high frequency oscillatory ventilation since birth on low settings, did receive surfactant, has had some hypotension in the first couple days after delivery, which is really common. The left ventricle is pushing against a very low pressure system in utero, and then when we clamp that umbilical cord, the pressure that the left ventricle has to push against increases exponentially, I'm sure. And then sometimes these babies have a little bit of heart failure, so the baby's on a little bit of dopamine to help with that. Is started still NPO, probably due to the dopamine and the hypotension, and on IV nutrition. And this baby had the same issue with the toes. And again, everything has reperfused except one of the toes on the left foot, it looks like. So we pulled that umbilical arterial line. And then we'll get a head ultrasound in a couple days and go from there. And we have baby, there's the Mason triplets, and they're all still here. They are 31 and 1 week triplets. They were an AB mono di pair, and the singleton was C. They were a C-section for non-reassuring heart tracing for baby A, and also some abnormal UA Dopplers. The babies were, I think they all received CPAP and the DR. They've been doing very well. They're very close to discharge. They're just kind of working on feeds. So they're all in room air at this point, and working on oral feeds with some gavage feeds for supplementation, but otherwise getting close to the door. So doing well. And all their head ultrasounds were normal. Baby C, it looks like, is undergoing an evaluation for multiple newborn screens with an elevated tyrosine level. We can see this in prematurity. It can be a transient hypertyrosinemia, but there's some amino acids and urine organic acids pending, and we're following with the CHOP metabolic folks. So hopefully we'll have that wrapped up and nothing to worry about by the time the baby's discharged, but it's something we're following. Then we have baby McQueen. This is a 26-weeker that is now 68 days old. It was a vaginal delivery after induction labor for chronic hypertension with superimposed preeclampsia. This baby was intubated for a couple of weeks, and then has now weaned down to room air, is ad lib feeding in a crib, and looking to hopefully go home very soon. This baby did have, this was an interesting case. The initial head ultrasound at 7 days of life was normal. But then we also repeat one on day of life 30 to look for leukomalacia in the periventricular area. And this baby had a significant amount of PVL. So whether there was some ischemic insult to those areas prior to, or in the first week after delivery. It's really tough to say, but we'll be following with neurology and get an MRI. Mom's requesting to have that MRI done at the institution where the baby's going to be following, so she wants one done outpatient at CHOP, and it's not going to impact the inpatient care of the baby. But we are able to accomplish those MRIs in the hospital without sedation sometimes. So we'll be talking with the mom to see if maybe she'll be amenable to that rather than having to be sedated at an outside hospital. And then baby Mitchell, this is a 24-week and 2-day baby that is now 75 days old, vaginal delivery for PPROM and preterm labor. Was intubated after birth, has now weaned down to bubble CPAP. From a cardiovascular standpoint, has been doing well, but does have a fibrin sheath in the IVC and poking into the right atrium, probably from the umbilical venous catheter that was present there right after the baby was born. So we'll be following that closely. Nothing to really do about that. It hopefully resorbs over time. The baby's on full volume feeds and doing well. And then we have baby Rodriguez. So this is a 28-week and 5-day baby that is 93 days old now. It was a C-section for breech in inciting preterm labor. This baby's been a tough one for 28 weeks. Has lung disease kind of out of proportion to the gestational age. So we're suspicious that something else is going on. So it was intubated initially and then had been extubated, nearly weaned down to room air. And then around Christmas time started to fly back up on respiratory settings, was initially on CPAP, then up to non-invasive positive pressure ventilation, and otherwise looking pretty well. At that time, they diagnosed a UTI that was treated, and then baby improved a little bit and then kind of got worse again. And we're worried that the baby is maybe chronically aspirating. Sometimes we'll see that with these preemies, they have reflux, they don't protect their airway well. There's also the possibility of a T fistula type that we don't readily see. But with the respiratory settings still being pretty high, we're trying post-pyloric feed. So we stick a nasogastric tube and kind of put it in a little bit further with a weight on the end and try to get it into the duodenum. So there's less chance for reflux, and hopefully we'll see some improvement in the baby's respiratory status with that. Cardiology is also following because when we have these babies with significant lung disease, they can sometimes develop pulmonary hypertension. And then otherwise, the baby's tolerating all feeds and otherwise growing well, looking well. It's just this respiratory status. It's a little out of proportion now at 42 weeks corrected age. So this baby's past term and still on non-invasive positive pressure. And then we have baby Torres. Baby is 26 week and 6-day, is now 50 days old, was a C-section for preterm labor. And baby's on bubble CPAP, doing well there. We are on full volume feeds and head ultrasounds were normal. Does have, oh no, we're following that. And then our ophthalmologist, when they came by for the first exam for this baby, felt that the optic nerves looked a little bit small. So we'll probably try to get an MRI prior to discharge, just to make sure that the midline structures in the brain look okay and those optic nerves are okay. And that was the last one.
Thank you, Dave. There was a baby with encephalopathy delivered term 38 weeks, baby Hiva. How's she doing?
List that I printed.
It's,
What was the last name? Sorry.
I don't remember the last name. Maybe
Bakari.
Bakari.
Okay. I know this baby and had a pretty significant skull deformity after birth too, that has now actually improved from my understanding. The baby's on room air, did have seizures early on, just one dose of phenobarbital calmed them down, has not had any repeat since then. The baby went through the cooling course pretty with really no issues other than the seizure, but tolerated choline is now is ad lib feeding, and we'll have an the brain MRI showed.
I've never seen this skull depression before. I guess
Yeah, are you able to pull it up there? Yes.
Yeah, I'm pulling it up.
Have
It's
you ever seen something
it's
like
very
this?
impressive.
The 3D reconstruction is pretty
Oh, yeah.
impressive. Never seen this before. I thought the baby was coming OP, so I wonder, I mean, I have no explanation, but pushing and difficult extraction.
Was it an operative delivery? No.
It was the rest of just
an
that
arrest of
C-section.
Oh, C-section.
Baby was OP and she
Yeah.
pushed for.
Yeah, was there anyone put like hand from the?
No, the patient was in dorso, in supine, no lithotomy, but they tried. And they did a reverse bridge extraction.
Yeah.
Apgar's 1-3.
Oh, God.
I've never seen this. So
It must have been really impacted against something.
it's is the baby looking better?
Yes. Yeah, it's doing well. And neurosurgery, of course, as neurosurgery always is, didn't have any concern for the skull. They said it'll work its way out. And
Is this skull still depressed?
sorry.
The skull is still depressed?
It's now improved. I haven't seen it myself, but I heard it had a pretty dramatic improvement.
Okay.
The MRI does look mildly abnormal, restricted diffusion in the bilateral parietal occipital cortical subcortical region. So there is some evidence of HIE there, and the baby's clinical exam and course was consistent with probably moderate HIE. So we'll be following with neurology, but ad lib feeding and otherwise looking well, so should go home relatively soon.
Thank you.
Sure.
Any other babies that we need have questions about?
No, thanks, Dave. We're gonna jump right to Virali has. Virali has a poster to present, and then we're gonna start orals at 10:30, so we can just squeeze in one poster before we start orals. Oral presentations for SMFM. Go ahead, Virali. I see you're there.
Okay, so I am presenting Sass's poster for her today because she's unable to make it. I guess we can kind of do something similar to what we did last time, where I can zoom in on the different sections and then take down feedback for her. So this poster was looking at risk factors associated with patients that have just severe preeclampsia versus patients that have both severe preeclampsia and FGR. Sorry.
I might, instead of in the objective saying severe preeclampsia complicated by FGR, just say and development.
Yeah, because they don't necessarily like one.
Like we don't.
Yeah, one might come first. It could, you know what I mean?
Yeah.
And instead of complicated by.
It could be one or the other one. Who comes first?
Yeah, that's what I mean. Yeah.
Okay.
Can you scroll up?
Do we need to include?
I would say associated with, not and. You know what I mean?
Where are you at?
No significant difference between BMI, race, age, comorbidities. It would be and comorbidity associated with, right?
Associated with the development of FGR.
Or wait, hold on. I'm trying to understand what this is saying.
Can you just Scroll, actually, once you're done with that, I just feel like I need to see more of the methods.
Or maybe just say BMI, race, age, and comorbidities not associated with FGR in pregnancies complicated by severe preeclampsia.
Okay, yeah.
And I wouldn't say, again, development of FGR, because they might have had FGR and then developed
Correct.
severe preeclampsia.
Okay.
Would you consider flipping the sentence and start with FGR in pregnancies and then have the no afterwards?
Yeah, I think that works too.
I don't know what everyone else thinks. It's just.
Yeah, I hear you. I'm trying to figure out I agree. I think this can be.
Because your mind
be
doesn't
more
know
clear
when you start the sentence, you don't know
where you're
what
going
it's
with
related
it.
to.
Yeah.
Yeah, I agree.
Okay.
I like
Yeah, we can
Emily's
flip it.
idea.
Yeah, I think you could say for the middle part, which is what we're still talking, in pregnancies with severe preeclampsia, BMI, race, age, and comorbidities were not associated with the presence of FGR or something like
Yeah.
that.
Okay.
Yeah, that's actually the best way to put it. Okay, you can move over.
Okay. Go back to the methods.
Yeah, I just want to see the rest of
Yeah.
it. Okay.
And go over to the result and conclusion.
Results.
So there's enough room that I would, spell out preeclampsia, or it's just like a lot of abbreviations where when you
Abbreviations.
have a poster and a lot of white space, you don't need to abbreviate so much.
Okay.
So you can abbreviate like in the table, but you don't have to, necessarily
In the results.
in the results.
Okay.
It's just cosmetic.
Yeah.
Also, SPEC is not while FGR is a very common acronym, SPEC could be superimposed preeclampsia or severe preeclampsia.
Yeah,
So
this
spell out
came
the
up.
word severe.
Okay, this came up with my poster last week. And I looked into the literature and there wasn't a specific abbreviation that they use, so we could do severe and then PEC.
Yeah, that's fine.
Okay.
It looks like the bullets under the third bullet point are just restating exactly what is in the table.
I agree.
I
would just delete that whole thing.
Okay.
Yeah, you don't need both.
Yeah, so after that, when comparing those and then just in parentheses, just say there were no significant differences, and then in parentheses, table 1.
Okay.
And then you don't need to list everything out because it's right down below.
Yeah.
And just take the colon.
Yeah. Like this, and then delete all
And
those.
then just delete all of that.
Yeah.
And since you have room, you could add a little cohort figure, like this number total, this had this, like that.
This had both.
Yeah, this had both, like that kind of thing. And then
Put that at the top.
yeah, and that really helps people know exactly what's being compared.
Yeah.
And what the starting cohort is. Scroll down.
I think that first sentence needs to be restated similar to the one in the middle.
Yeah.
Also, you just looked at black race alone. Okay. I wonder, for the paper, I wonder why, BMI is just categorical. I'm not sure why you wouldn't look at that as a continuous. Most of our patients have a BMI, as you can see, like 70% in general have a BMI over 30. So there's probably further gradations you could do. The other thing I don't see in this is gestational age of either diagnosis of severe preeclampsia or delivery. At the very least, I think gestational age at diagnosis would be an important thing to compare.
Okay.
Both severe preeclampsia. Severe. So gestational age of diagnosis of severe preeclampsia.
We can add that in.
I would take out the last bullet under your conclusion or rephrase it, because again, we don't know that.
Yeah, this is, I mean, a lot of times FGR comes before severe preeclampsia, actually.
Yeah, that's what my
Yeah, exactly.
poster
Most
showed.
of the time. Most of the time it's the other way around.
Mm-hmm.
So I would just say the associated with the concurrence of fetal growth restriction and severe preeclampsia. And I think it's always nice to have like a so what, you know, so like, so what, so that you can screen earlier to, you know, like, what are you going to do with this information?
Mm-hmm.
Closer, identify patients for closer follow-up.
Yeah.
You know, et cetera. Okay.
Did you look the other way? I mean, I'm curious.
There was another poster about FGR and severe.
Yeah, and they looked at
that.
we talked about it last week.
Yeah.
And it was looking, I can't remember what, like, the ones, I think they were diagnosed with FGR first and how many went on to have severe.
Yeah.
preeclampsia. That was the purpose of that.
Yeah,
project.
which was
resolved
yeah.
versus.
So that was a different one.
Oh,
There was a resolved
yes,
FGR
yes,
versus
yes.
not, and then there was one that
What's
was.
the other one right after?
Yeah.
Yeah, mine last week showed that typically FGR is diagnosed before severe preeclampsia, and it's on average 4 weeks before.
Yeah. I think that's what makes it this wording difficult.
Yeah.
Because usually it is the FGR that comes first, and this whole wording makes it seem like the other way around.
Yeah.
Okay. Then Mona, are you on?
Yes, I am.
Okay, why don't you, I know you have a time restraint, so why don't you go ahead?
All right, thank you very much. Let me share my screen.
And Mona, do you want to run through the whole thing, or you want to go through it slide by slide?
Is it okay if I run through the whole thing?
Yeah, usually I suggest running through the whole thing and we'll keep notes. And
perfect. Okay, you're able to see my screen? Okay. First of all, good morning, everyone. I'm Mona McCamry, for those who don't know me. I'm a combined MFM Genetics Fellow at Baylor College of Medicine. All right, so I'm gonna start. Can somebody time me, if that's okay?
What? Oh, sure.
Time me.
Hold on.
Yeah. All right. So first, I'd like to thank the Society of Maternal Fetal Medicine for the opportunity to present our work. Today, I'm going to be talking about why we need to rethink how cystic fibrosis carrier screening method should be modified, comparing comprehensive CFTR testing versus limited variant sets. To begin with, I'd like to disclose that
Mona, can you come closer to your microphone? We're having trouble hearing you.
Okay. Is this better?
Much better.
Okay. To begin with, I'd like to disclose that data for this analysis is given from a research collaboration with LabCorp. Now, cystic fibrosis is an autosomal recessive disorder caused by pathogenic variants in the CFTR gene. The incidence of cystic fibrosis varies by race and ethnicity, with the highest prevalence in non-Hispanic whites. Cystic fibrosis prevalence and carrier frequency varies by ancestry, as you can see. How CFTR gene encodes is a protein that is an ATP-gated chloride and bicarbonate channel expressed in lung, pancreas, liver, intestine, and sweat glands. Now, prenatal cystic fibrosis carrier screening was introduced back in 2001 for those with ethnicities that are considered high risk or high frequency, as well as patients with family history of cystic fibrosis. At the time, ACMG and ACOG initially recommended a 23 variant set to test for carrier screening in cystic fibrosis. And that variant set was primarily derived from non-Hispanic whites and Ashkenazi Jewish populations. In 2004, ACOG changes the recommendation to include pan-ethnic cystic fibrosis screening using the same 23 variant set. A few years later, commercial laboratories expanded this 23 set to a 32 variant set that incorporated 9 additional variants that were more considered to be more pan-ethnic and high-frequency variants in different populations. Detection rates did improve, but remained variable across populations. A substantial residual risk remains after negative variant set screening. Next generation sequencing, once that was later enabled full gene CFTR sequencing. And in 2017, when ACOG guidelines were published for regarding different carrier screenings and genetic conditions, had commented that it advised against routine full gene sequencing of CFTR gene, citing that there's only a modest incremental yield. Now, the goal of carrier screening is to identify offspring that are at risk for classic cystic fibrosis. In 2023, ACMG proposed a 100 variant set panel for testing for carrier screening in cystic fibrosis to improve the equity in testing. Many pathogenic variants remain rare or population specific, and full gene sequencing with deletion duplication analysis is not standard of care at this time. Our study's objective was to determine whether full gene CFTR sequencing with deletion duplication analysis identifies additional pathogenic or likely pathogenic variants beyond current variant sets. And we wanted to quantify the incremental diagnostic yield compared with 3 reference CFTR variant sets. This was a retrospective cohort review at a single national commercial laboratory that spanned the period of 10 months between March of 2023 till January of 2024. All patients that underwent full CFTR gene sequencing with deletion duplication analysis for the purposes of routine prenatal screening were included. Patients that had 1 or more pathogenic or likely pathogenic CFTR variants were included in the analysis. Any patient that had testing indication other than routine carrier screening was excluded. Negative or failed screens were also excluded. Variants were classified using laboratory standards, and variants of uncertain significance were not reported. Now, the detected variants were compared against 3 reference CFTR carrier screening variant sets, including the first being ACMG, the ACOG 23 variants, the commercial 32 variant set, and the ACMG 100. The study was approved by the IRB of Baylor College of Medicine and Thomas Jefferson University. Data sharing was governed by data user agreements between Baylor College of Medicine, Thomas Jefferson University, and LabCorp. All data were de-identified prior to the analysis. And for our results, the flowchart illustrates the flow of testing that occurred for CFTR specifically, gene sequencing and deletion duplication analysis. A total of 175,858 patients that underwent routine cystic fibrosis carrier screening were included. Of those, a total of 6,142 cystic fibrosis carrier were identified, which is 3.5% of the tested cohort. Of these, 98.9% of carriers were detected due to CFTR full gene sequencing, while 1.1% of the carriers were identified due to deletion duplication analysis. A total of 340 distinct pathogenic and likely pathogenic CFTR variants were identified. When compared with standard variant sets, the ACMG ACOG 23 would have detected only 6.8% of those. When compared to the commercial 32 variant set, it would have only detected 9.4% of those. And when the ACMG 100 would have been utilized, then it would have only detected 29.4% of the 340 pathogenic variants. So overall, 70.6% of pathogenic variants would have been missed, even by the most inclusive variant set. Out of the 6,142 cystic fibrosis carriers that were identified by full gene CFTR testing, the ACMG ACOG 23 would have detected only 55% of carriers. The 32 commercial variant set would have detected only 57.5% of carriers, and the ACMG 100 would have only detected 65.8% of carriers. This table illustrates the aforementioned results, and you can see in this row where it shows that the full CFTR gene sequencing with deletion duplication analysis, the carriers detected were 6,142. And it can see how the percentage of the missed carriers and the missed variants were illustrated when you compared them to the comparator variant sets. In this diagram, we illustrate the most frequent CFTR pathogenic variants identified in the cohort. Interestingly, 6 of the 10 most frequent variants were absent from all 3 standard comparator sets. Those were in the color orange. To further elaborate on those specific common variants, we mapped the most common variants across the CFTR gene structure, and we noted how the variants were dispersed throughout the CFTR coding region, including canonical splice site, missense, and in-frame deletion changes. In this figure, you can see how the CFTR gene, which is located on chromosome 7 at the Q arm of the chromosome, the CFTR gene is made of 27 exons. And in this region, we illustrate the most frequent variants that were detected by full gene sequencing versus the variants that are detected by variant sets. And they're all dispersed across the genome of the CFTR gene. For our key findings, full gene CFTR sequencing with deletion duplication analysis identified more than 70% of distinct pathogenic or likely pathogenic variants that are not represented in current guideline-based variant sets. At the individual level, 1/3 to 1/2 of cystic fibrosis carriers would have been missed by existing ACMG, ACOG23, the 32 commercial variant, or ACMG 100 variant sets. And 6 of the 10 most frequent pathogenic variants in this national cohort were absent from all 3 reference variant sets. The ACMG ACOG23 panel was developed primarily from non-Hispanic white and Ashkenazi Jewish datasets, leading to reduced detection in other ancestry groups. Although expanded variant sets improve detection, substantial residual risk persists, particularly for individuals of non-European ancestry. CFTR variant set-based screening results in inequitable carrier detection across diverse US populations. Our study has several strengths, including that it's a large national cohort of more than 175,000 individuals that underwent routine reproductive carrier screening. This study utilizes the use of full gene CFTR sequencing with deletion duplication analysis in a CLIA certified lab. It provides direct comparison to multiple guideline-based variant sets, and it captures both recurrent and rare pathogenic variants reflecting real-world CFTR variant diversity. However, this study is not without limitations, as the data was derived from only a single commercial lab, which may limit generalizability. Race and ethnicity data was unavailable, precluding ancestry-specific performance analysis. Variant classification and technical limitations, such as deep intronic or complex structural variants, may persist. And implementation considerations, including cost effectiveness, interpretation burden, and genetic counseling infrastructure, is not included. Future directions include pursuing future research that would evaluate the cost effectiveness, the counseling needs, and health system integration to guide implementation at scale. Such studies will be essential to better inform guideline updates and ensure that advances in testing translate into equitable benefits for patients and families. In conclusion, CFTR full gene sequencing with deletion duplication analysis outperforms currently recommended variant set-based approaches. This approach captures a broader and a more representative variant spectrum, including high-frequency pathogenic and likely pathogenic variants missed by existing variant sets. Our findings support the adoption of comprehensive CFTR testing as the new standard for carrier screening in the United States to improve equity and accuracy across diverse populations. And with that, I conclude my talk. I'd like to acknowledge all of my co-authors who made this work possible. And I'd like to also thank both the Baylor College of Medicine for their support and LabCorp and Jefferson for their collaboration and support. Thank you very much, and I'll take questions.
Wonderful, Mona. Congratulations on this really, really important work. I'm not surprised it was an oral. I was so excited when you presented it initially, and I do hope that it is practice changing for equity purposes, as you've highlighted.
Thank you.
You were about a minute over, and I think one easy thing is you have a slide on IRB and data sharing agreements. You can just delete that slide. It's not at all necessary. And
Perfect. Okay.
that'll probably shave at least 30 seconds off your talk.
Wonderful.
Mona, can we go,
But let's just go from the beginning and we'll just go slide by slide. I think this is again just purely cosmetic, but when you have when you're thinking about your title, variant sets is kind of stands out because it's on a line by itself. So I would make verse and then make limited variant set as its own line.
Got it. Okay.
You know what I mean? Exactly. This is just like purely cosmetic things, but it just helps. Yeah. There you go.
Perfect.
Okay. That's an important disclosure. Thank you. Background. I think that was fine. Next slide. So for this, my comment was this should just be a pie chart of some kind or a bar graph. I think it's just a lot of text. I think throughout you could have more figures. Any other yeah. Okay. Next. I think I didn't have any comments on this slide. Anyone? Okay. Oh, so for your evolution of variant sets, again, just to break up the text, you can make it a timeline figure where you press the advanced button and a new box pops up. So 2004, ACOG recommends pan-ethnic seeding. During this time period, commercial labs expanded to 32 variants. And you know what I mean? So it's just a way to make it so it's not just only text, because this is a very text-heavy presentation. And so the next 3 slides, I think, could be kind of presented graphically that way. And if you do smart art in PowerPoint, it's pretty easy to make it look like that, except for struggles.
Thank you. Yeah, that's actually helpful.
Yeah. I think
Go ahead.
bullet here is similar to what Rubisha said. I think graphically illustrating the residual risk might be really valuable rather than just mentioning substantial residual risk remains. So again, having a bar graph that's potentially here's your carrier risk as a, white, non-Hispanic, Ashkenazi Jewish, here's what your carrier risk is after screening, and sort of see where the differences in shading are based on ethnicity.
Or if it's not known, you can just have then say that it is unclear what is the residual risk after a negative variant set based on race, ethnicity, whatever.
Gotcha. Yes.
The only thing I had about this is the goal of carrier screening. I feel like if you're going to say that should be earlier.
Yeah.
In the talk overall, at the very beginning.
Yes.
Yeah. And I know we all know this, but it might also be helpful early in the beginning to sort of say
because this needs immediate infant intervention, etc.
Life limiting,
etc. Yeah. So exactly. So in this background, and I would start with your next bullet can be the goal of carrier screening is to identify this because of the significant infant morbidity associated with delay in diagnosis, whatever. Yeah.
Yeah.
And then if you go back, so again, this can be sort of continuing your timeline of then in 2023, for the variant set, and then you could have a box that pops up this is what's remaining. Many variants remain rare. Full genome sequencing is not standard of care. But again, it can be graphic.
Yeah, you might even be able to return to your prior timeline.
Yeah,
and just add
to it, right?
Basically copy paste the slide and add to it.
Mm-hmm.
Yeah.
And that allows people to keep that full spectrum sort of in their head to see because you're marching forward, right? We're marching forward in our progress, and the next step forward is full sequencing. Okay, next. I think that was fine. It was very clear. I want to say everything you said was very clear. You spoke very clearly throughout the whole talk.
Thank you.
For the study design, I think it would be helpful to say that patients opted for, like, why, you know, basically, like, why are these patients getting full CFTR gene sequencing? Did they have some family history concern? Was it just their insurance covered it, so they got it? Do you not know? But I think that's an important question that will.
So LabCorp does it for everyone. Anybody who's undergoing CF carrier screening.
You should say that.
Okay.
Then how? Okay, so anyone who's getting CF carrier screening at LabCorp gets full gene sequencing. Is that what you're saying?
Yes.
Then that should be, and so you said single national commercial laboratory. The next line should be the standard screening for standard CF screening for LabCorp is to do full genome sequencing.
Mona, it's Stephanie. This is like probably a little bit more granular, but I would just double check. You are 100% right that LabCorp kind of did away with their 32 mutation panel, and I don't even know if they still offer the 97. So we were kind of like diverted into doing full gene sequencing. I remember it going live January 5th. I just can't remember if it was in 2024 or in 2023. So I would just double check on that because there might be other reasons why they had the full sequencing. I know a lot of patients probably got it through like their Inheritess carrier screening panels, which is automatically going to be sequencing versus like an OB ordering it as part of like first trimester, like prenatal labs.
Yes, so you are very correct. So it did start in March 2023. That's why the time period was March 23 to January 2024. So you will see here, sorry, I skipped a few slides just to explain. The number of individuals between that time period that were tested for cystic fibrosis at LabCorp that underwent full sequencing was this number. And so we excluded and we went through the indication for testing. And so we excluded anything that had a family history or suspicion for cystic fibrosis, for example, were also excluded. So we only included those that had routine carrier.
That should be, if you go back to your methods.
Yes.
Study design. So I would say in March 2023, that's was standards because that's why you did the time period. And then you can have a bullet that says exclusions.
She has one on the next slide.
Okay, perfect. And then this is just in general, again, for just your slides. If you have bullets like that, like spread it out across the slide, increase the spacing between the bullets or the font. You know what I mean? And that's for all the slides. Just so it's easier to see and read. Okay. Anything else on this slide, guys? Okay, next. And then again, similarly, I would just space this out. But I thought it was very clear. And then again, the font can all be bigger too.
I like larger fonts.
Next slide.
We're gonna delete it.
Oh, this one.
So delete that slide. This slide, that image on the side is not legible in any way. And I don't know if it's redundant with the text or not, but like, is that text on the left-hand side the same as what's in that figure or no?
Slightly different, yeah.
So I would make it all into a figure somehow and make them much bigger.
I would say you don't need it.
Well, usually cohort flow is usually in a figure.
Making it more concise, smaller.
Yeah.
Wording.
Okay.
Like this should be in like a cohort flow diagram, but it's not. You can't see it. If you need to make two flow diagrams because of the levels of, kind of weeding out, that's fine. But this is, Yeah, I would work on that.
Got it.
This needs to be a bar graph. So you can say like your x-axis can be whole gene sequencing, which would be then, I guess 100% of variants identified, and then ACOG, ACMG, whatever. And you can have a solid for variants identified and like shaded for this is the percent missed.
I think this information is in the table.
Yeah, we'll get to that too.
Right?
Yeah.
So you're repeating the information.
Yeah. So make
Okay.
that bar graph, make the next one a bar graph, and then you don't need the table because that's redundant.
One or the other one.
Yeah.
I think the information.
That whole slide.
And then this is this, was this new information or it looks like it was the same? Is that correct?
Yeah, it's the same. It only just
Yeah.
the only thing is like I'm talking about what would have been detected. And I guess I just wanted to show what would have been missed, but I don't think.
Yeah, so you can, if you do a bar graph, you can do that, right? Where you have like within the bar, like everyone's bar goes to 100, except you have one color for detected and a shade or
yeah,
you're not even off for miss. So you're like yes, no, and that way you can see, you can present it both ways. You can spend longer, right? You can have that slide up for longer as you're talking through it. And that's what people want. They want to see that. They want time to take the picture. So you want to, that's the slide that you want to spend a full minute on.
yes.
And same thing with the carrier frequency one.
Thank you. That's very helpful.
Next one. This was nice. The y-axis is not, you can't read the axes, like you can't read any of the numbers. So the font needs to be bigger.
Okay.
And I can't tell what the colors mean if you go back up. So is it like,
It's over there. It's just very small.
yeah, so everything, just like all the fonts are just way too small. You can't tell what the figure is trying to say.
Got it.
The other thing that you can do, if you go back on that slide, if 6 of the 10 frequent variants, does that coincide with the orange?
Yeah.
So then you can make that text orange in color.
Okay. Yeah, but I'll make it.
Or make it a dark orange, yeah.
A
So
dark orange, yeah.
The eye will kind of line up and see it like that.
Okay. Yeah. Okay. Lovely. Thank you.
This, I was wondering, can you just say this with the next slide?
Yeah, absolutely. I thought about that too.
Like take that slide out and just, that'll be what you say on this slide.
Okay. Is it helpful at all, the slide? I'm just so proud of the diagram that I made it. I just wanted to
I
insert
think
it.
it's fine. Yeah, no, I think it's good.
Okay.
There's definitely people that'll want that information.
I know one of them.
I don't know what it means.
No, I think it's actually very visually appealing. Yes.
It is.
Thank you.
It's a beautiful graphic. Similarly, like the text can all be bigger. Just think
Okay.
about these are things people are going to be taking a picture of and texting out to their friends. So you want it to be a legible image.
Okay. All right.
It's just wordy. I don't know if you want to split this up into different slides. Or bold the important part of each bullet point. I didn't have enough time to kind of think about it more, but just that it's a lot of text.
Okay.
It's what you say is really important. Again, I just feel like it's lost in text when it's such an important point. But I can't think of I have to like think a little bit about how to, if that's something that can be changed or not. But it's, to me, this is like just such an important point here.
Yes. Okay. I mean, I can try to
And I
limit
wonder
the
if you can
words.
just take out the middle bullet point and just say, yeah. Because that's what you found, right? Like this is the conclusion of your study, that there is inequitable carrier detection.
Yeah.
The other thing that you can do in that equity implication slide is again, have another bar graph showing what is the carrier frequency or like by race, to just highlight like this is not like just a Caucasian problem, but it's a Caucasian detection, right? So something like that.
Okay.
So just illustrating the groups that are being missed, basically, in graphic form. This can be 2 slides.
Small letters are too small.
Yeah, it's again, and you can say more than is bulleted. Again, I couldn't read through it enough to like cut back, but think about limiting your bullet points to 1 to 2 lines, and you can talk more than what's written on the slide. But you don't want people so busy like reading that they're not listening.
Yeah.
So for example, like if you go back up, just to give you an idea. So in limitations, you can just say external validity and then say why is external validity limited? You know what I mean? And so it just again, cut back on that wordiness. I think the race and ethnicity data unavailable is really an important point, because I think people would have loved to know that information. And I think one of the important strengths is that this was an unselected cohort.
Okay.
Meaning everyone who came for screening got this. You know what I mean?
Yes.
I think that's a huge strength of this.
Okay. I'll fix that. Okay.
And again, that's something that you can say out loud, not necessarily that you need to write out, but.
Yeah. Like I can say as part of the.
Exactly.
Yeah. Future directions.
And again, this can be, you already say future directions, then you don't need to say future research should evaluate. You can just say future directions, cost effectiveness, counseling needs, health system implementation.
Yeah.
And then that last line, again, you can either just say it or make it like a 1 bullet point, like ultimate goal is to provide, you know what I mean? Because I think that's the other, most important point is ultimately what we're trying to do is provide equitable care. Okay, I think that was fine. Yeah.
Yeah, I mean, you have room to do larger fonts.
Mm-hmm. For all your slides.
Especially for this one.
Yeah.
Got it. Okay. Thank you very much. This was really, really helpful.
You got the message, I think, and this is for everyone. Even an oral presentation, SMFM, it's not always once in a lifetime experience, but often. And it's really not for Rupsha, but for most people. And you're gonna have hundreds, maybe thousands of people listening. And it's a visual experience. Most of us are visual learners. So the data and the is wonderful, but if you present it in a way that it's more compelling, colorful, graphic, I think you'll grab even more attention. But
Thank you.
Okay, we have two more. We'll have, I think it's our Sinai group here. If they're here, we'll have.
We are. Yeah, we're here.
Hi. Welcome. You guys can go next. I know it's hard to coordinate with different sites, so we'll just have Mimi go last. Go ahead.
Okay, perfect. Let me pull up my slides, and I apologize at this exact moment. The strikers are playing a marching band outside my window.
Wait, what?
Marching band.
There's a marching band right now outside of our window.
There's a nursing strike going on at a bunch of New York hospitals right now.
Oh, okay.
Huge issue.
Okay. Do you see my slides?
Yeah, go ahead.
Okay, perfect. Thank you guys so much. I'm Victoria. I'm one of the second-year MFM Fellows at Mount Sinai. Today, I will be presenting the effects of regions of homozygosity identified on prenatal chromosomal microarray on adverse pregnancy outcomes. The data presented today reflect a larger sample size and updated statistics after additional IRB approval. We have no financial relationships to disclose. Compared with karyotyping, which is limited to abnormalities 5 to 10 megabases in size, chromosomal microarray detects microdeletions and microduplications as small as 50 to 100 kilobases. This increased resolution expands prenatal detection, but also introduces new counseling challenges. Despite rapid advances in medical genetics, important knowledge gaps remain in how we interpret and manage regions of homozygosity, or ROH, also known as absence of heterozygosity. These contiguous stretches of homozygous single nucleotide polymorphisms can arise from shared parental ancestry through identity by descent or from uniparental disomy. Although ROH are increasingly detected by chromosomal microarray, their clinical significance remains poorly understood. This is especially relevant given that approximately 8 to 10% of pregnancies occur in consanguineous partnerships, which are customary in some cultural and geographic populations. Currently, there are no standardized guidelines for counseling pregnant patients when ROH are identified, creating uncertainty for both clinicians and families. This chromosomal microarray demonstrates a long region of homozygosity greater than 8 megabases, including its chromosomal location and the percentage of the autosomal genome affected, shown on the right. The extent of ROH helps estimate parental relatedness. In this case, the patient and her partner were known first cousins. This chromosomal microarray demonstrates a high density of short ROH, reported only at the 99th percentile, reflecting increased allele homozygosity from multiple short contiguous regions. This pattern may suggest a geographically or socially limited gene pool. Here, both partners are from Mexico, but denied shared ancestry. The objective of the study is to examine the risk of adverse pregnancy outcomes in pregnancies with regions of homozygosity identified on chromosomal microarray. We conducted a retrospective study of patients who underwent prenatal diagnostic testing at a single tertiary care center between November 2022 and December 2024. Maternal and neonatal medical records were reviewed to collect demographic information, medical comorbidities, genetic findings, and delivery outcomes. We defined a composite adverse pregnancy outcome that included preterm birth, preterm pre-labor rupture of membranes, fetal growth restriction, hypertensive disorders of pregnancy, pregnancy loss, and neonatal intensive care unit admission. We excluded multifetal gestations, including vanishing twins and selective reductions, as well as cases with confirmed aneuploidies, microdeletions, microduplications, or any major congenital anomaly. Continuous variables were compared between groups using students' t-tests to assess differences in means and Mann-Whitney u-tests to assess differences in medians. Chi-squared and Fisher tests were used to compare proportional differences. Multivariable logistic regression models were used to estimate odds ratios for adverse pregnancy outcomes while controlling for individual level covariates. To further reduce confounding, we performed Mahalanobis distance matching to simulate a randomized trial, generating a 1-to-3 matched cohort of ROH to non-ROH pregnancies. Rather than matching one variable, participants are matched by multiple variables at the same time prior to analysis. Once we match individuals who appear very similar at baseline, we can more fairly compare outcomes between groups. Now on to the results. A total of 726 patients were included in the study, and ROH were identified in 18 patients, representing only 2.5% of the cohort. Of these, 8 patients had long ROH, 8 patients had high-density short ROH, and 2 patients had both. Compared with the non-ROH group, individuals with ROH were significantly younger, more often identified as non-white or Hispanic, more likely to have public insurance or be uninsured, have a higher BMI, and have higher gravidity. All outcome analyses were appropriately adjusted to account for these baseline differences. Overall, 56% of pregnancies with ROH experience an adverse pregnancy outcome, compared with 25% of pregnancies without. After adjustment for confounders, pregnancies with ROH had 3.2-fold increased odds of APO. However, this finding was not significant in the matched analysis. The individual outcomes contributing to the differences are shown here. Visually, you can see that there is a stark difference in the fetal growth restriction between the ROH group and the non-ROH group. In fact, when ROH were evaluated as independent risk factors for each specific outcome, their presence was associated with an 8.2-fold increase in the odds of fetal growth restriction, which remains significant in the matched analysis. To further strengthen the findings, pregnancies with known risk factors for fetal growth restriction, including but not limited to placental abnormalities and assisted reproductive technology, were excluded from the analysis. When further investigating ROH subtypes, pregnancies with long ROH had a significantly higher risk of adverse outcomes, with an 8.5-fold increase in the odds of an APO, and this remains significant in the matched analysis. In contrast, the presence of high-density short ROH was not associated with an increased risk of an APO, suggesting that ROH length may be more clinically relevant than density. Overall, we found that pregnancies with ROH resulted in 3.2 greater odds of an APO, and specifically an 8.2 greater odds of FGR. When we stratified by ROH type, long ROH were significantly associated with APOs with an odds ratio of 8.6. In contrast, a high density of short ROH was not associated with an increased risk of APOs. As the first study of its kind, this study addresses a gap where no prior data existed and offers early evidence that may influence clinical decision-making. We strengthened the analysis using a pseudo-randomized approach with Mahalanobis distance matching. Key limitations include limited generalizability due to the study population, a small number of ROH cases, and reliance on a single laboratory data source. Therefore, future work should include larger, multi-centered studies to improve generalizability, inclusion of data from additional labs, and further sub-analyses focusing on ROH type and size. This may include the percentage of ROH in the genome and the specific chromosomal location of the ROH itself. In conclusion, regions of homozygosity identified on prenatal chromosomal microarray were associated with an increased risk of adverse pregnancy outcomes, particularly fetal growth restriction. These findings underscore the need for larger prospective studies to confirm this association and to create standardized approaches to interpretation and counseling. Thank you to my mentor, Dr. Gilroy, and my MFM family at Mount Sinai for endless mentorship and support. Thank you to my clinical research program director, Nika, for holding my hand through my research endeavors. And then thank you to the MFM division at Jefferson for listening to this practice run and providing feedback. I will include a reference slide, but this is the end of my presentation, and I'll take any questions.
Great. Really well done. I unfortunately started timing late, so you don't know if you're over 10 minutes or not, but it didn't seem
Okay.
Can you go from the beginning and we'll...
Yeah, let me share my screen again. Okay. Perfect.
That's fine. That's okay. I thought your introduction, I really liked the graphics and how you highlighted the results in the introduction. I thought it was really helpful.
Okay.
So you can you just go slide by side. Did anyone have any comments on?
I didn't like this slide of the quality of the picture is poor. Can you go back?
But this one?
No, the
Like
report.
Oh.
I don't know if you can improve the quality of the picture. If it comes in a PDF format, you can highlight the yellow
okay.
PDF, and then you copy paste the screen and cut, and you can do a little bit of saturation contrast to give, because you cannot see anything.
Okay.
Just send it to Amanda.
Send it to me if you want. I can fix it, but yeah, it's not a good quality.
You could also just box it, like the area instead, so that way it's clear for people to read instead of highlighting.
Okay.
Basically just using like a pen.
I'll just say I did like the highlighting actually a lot, but
okay.
Minority. Okay,
Sounds
next.
good. I will do that for both of these slides then. Oh.
Yep, that's good. You can also make the font bigger.
For this?
Yeah.
Yeah, this is me.
Yeah, much better.
The main question I had was what was the reason for the microarray? Was that collected at all?
Yes. I am currently looking through to see if I can incorporate it as a figure, probably somewhere after this slide.
So it would be before. So it would be before, right? Because like the reason for microarray would be like your description of your cohort. So before you talk about results, I would talk. So it would be like in this slide, basically. It's part of your.
Okay.
Oh no, the next slide. It would be like in this. Just go to that slide. So in the 726 patients were included in the study.
Yeah.
That's where I would describe why they got.
Oh. Okay, do you think I can?
Because over here, you're describing your cohort. So the indication for
Yes.
testing would be in your description of your cohort.
Okay. Do you think I can add the figure on one half of the screen, or would that be too busy?
Yeah, that's probably fine. It's hard to know without seeing the figure, but
Okay.
There's a lot of empty space on this slide, so.
Okay. Sounds good.
Or if you need room, you would just say 726 patients and then have the figure, and then your next slide, you would talk about the 18 patients with ROH, and that would be its own slide.
I see what you're saying. Okay.
You know what I mean?
Yeah.
Because you're stepwise in describing your cohort.
Mm-hmm.
I have one quick general comment. You're so familiar with ROH, yourself, but there'll be people coming in and out of the room and they're seeing ROH, it's not a common, things like PPROM or, birth or something. I wonder if in some of the slides where you have space, you can put like a graphic of ROH, so that people kind of can have a visual of, what it is. Maybe one of the slides from the beginning. So just something to think about, so that you don't want to repeat it. I understand it's a long term. So the acronym is fine, but maybe something that kind of
shows visually, like in red, like this is what high density, this is what, I'm sure you could find like a generic graphic about long ROH, what that looks like versus high density short ROH, what that looks like within an array.
Yeah. I'll try that.
The other thing, I don't know if you guys have BioRender, but there's a lot of graphics that you can search that other people have made. You have to credit, obviously, but it's worth looking at.
Yeah, I've never heard of it until Mona incorporated it in her presentation. So now I'm definitely going to have to look.
I actually was recommended it by a reviewer before, and I was like, oh, good work. Okay. Keep going, so I know we still have another presentation to go through. Okay, next.
Yeah, I kind of jumped. Sorry, I jumped. Was the slide okay?
Oh, yeah, we were on results, I think. Oh, no, did we skip? Oh, okay.
I kind of skipped a little bit.
Yeah, I think this slide was fine. I would just, in your composite pregnancy outcome.
Yeah.
That's really important there. I would bullet each individual one, maybe, or make it, or have that be its own slide, because that's your outcome.
Okay.
So that it's just like clear, like each line should be each outcome, just so it's very easy to see.
Okay.
This was good. You could spend less time talking about your statistical the first two bullet points.
More time talking.
And more time on the next two bullet points. I mean, even especially the last one, I think people know what multivariable regression models are, but I think I would spend more time talking about the last one, bullet point. And especially if you need to cut back time. Like, yeah. You can even take out the first two bullet points altogether. Just say them.
Oh, okay.
Yeah, continue, no one needs to, the main analysis is not your univariate comparison, right? So I would just, you just don't need to spend time on that part. This was good because you talk about this. I was curious personally how this was different from propensity score matching, but you don't need to answer my question now. We can talk offline.
Okay. And then we did this one, and then so now we're at here.
Wait, sorry, just go back up one more before then. No, this one. Yeah.
Okay.
So again, because this is not a method that people will be as familiar with, I would either have a graphical representation, or if you're going to base it on characteristics, have it listed out so it's more clear how that's happening. And yeah, like how many matches per case or whatever. Is it?
Oh, okay.
You know what I mean?
Yeah. And I do have a figure, so I can put that.
Yeah. So I would, again, spend more time talking about
this.
That require more explanation. Next.
Okay.
Oh, we talked about that slide.
Yep.
I think you could just make the font size bigger, maybe.
Okay.
The numbers are hard to read, and again, there's a lot of white space, so probably.
Okay.
And then I don't know if you compared indication for microarray, and And I was wondering
Mm.
if the FGR, did any of these patients had FGR diagnosed at the time of their diagnostic testing or no?
We do have that information. We did not run the stats on that information.
Because that would be right, if people who had, FGR got diagnostic testing and you excluded other reasons, that could be a, selection bias there in your.
Mm. Okay.
This was, so in general with the results, it was just hard to follow the various comparisons.
Okay.
Because there's the adjusted and then there's the matched. And so like, how am I supposed to interpret that? Like what value is important and what are we drawing a conclusion from?
Okay. The conclusion is more from the adjusted odds ratio.
And why?
So I guess I should explain more in the Mahalanobis distance matching, but because the distance matching sample size is actually quite small, and it's very I guess finicky to outliers. So the adjusted value is probably more accurate than the match.
So I think if you don't think it's a good test to have done, I mean, this is a 10-minute presentation to convey your results, then I don't know about including it. Again, I'm not familiar with it statistically, so certainly if statistically speaking, you should include it, then I would separate it somehow, but it's
okay.
It was confusing to follow because I didn't know which was true. And then your conclusion was that there was a difference. And I was like, wait, but I thought it wasn't different. So it's like,
gotcha.
For the purpose of a 10-minute presentation, I think you can like pick what you want to convey.
Okay. Okay. And then I'll do the same thing for the other subsequent slides.
Yeah, whatever you choose.
Yeah, whatever it is that you guys decide.
I don't think that the title of this slide is exactly accurate because it's not versus FGR. It's not
just risk of FGR, right?
I just think versus is the wrong perhaps
term
in the middle there.
Okay.
You just say, right, it's just the risk of FGR in ROH, right? That's what you're conveying here.
It's like, like
the odds, right? Your odds ratio, odds for ROH, for FGR, if you have ROH versus not.
Correct. After they removed other risk factors.
The other thing to think about is if you are going to keep both adjusted and matched, then you do need to talk about why it's different.
Okay.
Or why one is favored. Because it looks like in the other findings, it is consistent across findings.
Yeah, except for, I think.
So if you want to keep it to say we looked at, because that does add strength, right? There's different ways of addressing confounding, and it does strengthen your analysis when you adjust for confounding with different statistical methods and you keep getting the same result. That means something. And so, I think it's just whether it's the specific composite APIA was maybe too big of a, too messy of a picture or whatever it is you decide, but you just need to address it. Okay, keep going.
Okay.
Here. And the other thing, just for, throughout the results, if there's anything that you can display graphically, like bar graph of percent by no ROH, long ROH, you know what I mean? Was that like a stepwise comparison that you did?
For yes, but because the N of long ROH is only 10, the non-ROH is going to be like the 700 minus 10.
But so here, go forward another. Because these are distinct, right? The high density short ROH is separate, or do people have both?
There are 2 people that have both, but this is
Okay.
the 10 people that had high density short ROH versus everyone else.
Okay. I was just wondering if like I was just thinking like a graph of no ROH, long ROH, and high density ROH for the rate of your outcome.
Okay.
But if that doesn't make sense, that's okay too.
It just may be challenging because I think it's going to look
It's
really
like
small.
different. Yeah, okay. Okay.
Yeah.
The other thing, if you go back, just like again in a presentation, like if instead of like your title can say what the finding is. So you could say similar APO and high density versus short ROH versus no, greater APO with long ROH versus, you know what I mean? Like it could just be the statement.
Gotcha.
So people don't need to like interpret the data themselves. Again, you want to minimize the time people are spending trying to figure out what's written on the slide.
Mm-hmm.
Yeah, this was the one that I was confused by because of the difference in matched.
Matched and adjustment. Adjusted. Mhm.
And because you say adjusted and then you have the matched after, it almost makes it seem like the matched is the more, and even from your description of the methods, it makes it seem like the matched is actually the better testing comparison than the adjusted. So again, I would just.
Yeah, I'll have to make sure that I explain it. Okay. And then I'll do the same. So then that way the principal findings are not as confusing.
And then I wouldn't say long ROH also, right? Because that's like, that's within. So I would just say specifically long ROH. So you don't want to like repeat your results. Like what's your principal finding? Is that the point is that it seems to be that long ROH specifically may be associated. Is that accurate?
Yeah.
So I would just say that, not repeat what your results are.
Okay.
Again, I think you can split up strengths and limitations.
In like 2 separate slides?
2 separate slides, yeah.
Okay.
And again, here you say there's greater rigor using the matching, so.
It can be confusing.
Yeah, and at some point you need to address the discrepancy in the findings.
Okay.
Yep.
Okay.
I mean, limitations, there's always unmeasured confounding. But.
Okay.
So I think for future research, I would, again, just like think about the big picture. So like the first 2 bullet points are kind of redundant, right? So basically 1 is bigger. So do more, like external validation.
Yeah.
And 2 would be further. So I think the really important thing, again, to me would be the sub-analysis by ROH type and size, because that's where there does seem to be, a difference. And the biggest thing that I was wondering about is like, what would be the pathophysiological basis for this? And I was kind of looking for maybe a slide that would say, and this is why we think that these repeated sequencing areas can result in placentally mediated diseases.
Okay. I can try to incorporate that.
Yeah, so even just like 1 slide about it, because that kind of will direct your future research too, right? Like,
yeah. Okay.
This can just be spaced out. And it was felt a little bit redundant, so I think you could think about combining.
Okay. And then I need a reference slide. Okay. And then acknowledgements, and then that's it.
Yeah, and I'll say you don't have to have a reference slide. If you instead you can just have the references on the slide. Like, what do you need references for?
Well, I was wondering if I needed references for like the information where I got the definition of ROH and whatnot. I did for these pictures because they came from a textbook. So
Yeah, exactly. So if that's fine, but otherwise you don't need a reference slide for like general information.
Okay.
If you have like specific statistics that came from a specific paper, then put that reference on the slide.
Gotcha. Okay.
And that's really the better way to do it. Again, if anyone's taking a picture and distributing images, it's on the slide that you are citing someone else. You know what I mean?
Yeah. Okay. Great.
A very minor last point, well done, and take all this, all positive, reinforcement, really well done. Is you'll be in front of people that have done this, a lot of people with genetic background and stuff. At some point, you say there is nothing really on this in the literature. Just make sure that that's true. Sometimes even if I know there's nothing, I say limited myself so that just in case I miss something. Just something to think about, because somebody can come back and say, oh, I have some data on preeclampsia or preterm birth for this, or FGR or whatever, and maybe in some genetic journal you haven't looked at. It's great. It's so novel, but yeah. Well done.
Thank you.
Okay. Thanks for sharing with us. It's
thank you so much.
Great for us to hear your work.
Thanks for your time.
And I would really hammer home, I really like, I think like the immediate effect would be like, what am I going to do tomorrow is if I see this, like maybe I'm going to do increased surveillance, so I really highlight like, what does this mean? Because I think that's, like, to me, the key takeaway points were the difference between the long and high density short, and the fact that something that we don't otherwise follow up has a high rate of something that we can detect with antenatal surveillance. And so that's a big deal. So I think, less text, more big picture for like your last conclusions, because you already listed the results.
Sounds good. Thank you.
Okay, go ahead.
All
Sorry
right.
for running over. Go ahead.
My name is Mimi, and I'm a third-year resident at Thomas Jefferson, and I will be applying into MFM Fellowship. I know that COVID-19 occurred in 2019, and thank God that we found vaccines. But vaccine development is an ongoing issue. So I'd like to talk to you about the contribution of antibody subtypes to breast milk immunity against pregnant patients who had COVID-19 and vaccine-exposed pregnancies. And these are the people that I worked with. And thank you to Dr. Bollig. Okay, these are my...
it didn't advance.
Oh, you didn't advance.
Okay.
Maybe share. Sorry. You just is it, and I'll just have to share.
Do you have any posters to present?
The screen.
We did already.
I did the posters.
We just had one.
Just one.
Yeah.
So this is the last thing.
Yeah.
Oh, that's
There we go.
Yeah.
Okay.
These are my...
Need for any more?
Okay. These are my funding sources, and I have no conflicts of interest. Okay, so we know that the infant immune system relies heavily on passive immunity from mother, especially in the first 6 months of life. So we know that breast milk antibodies aid in the developing of the neonatal microbiome, especially protection against enteric and respiratory diseases. So in general, the breast milks will supply secretory IgA, IgG, and IgMs that will guard against mucosal surfaces against pathogens like the COVID virus. So I put up this graphic here, just in general, when we get the COVID vaccine, mom will generate the IgGs, and the IgGs will be transferred via the maternal blood and from the placenta to fetus. Secondly, through breastfeeding, we will get the secretory IgA, IgG, and IgMs through breast milk. And so baby will get this through passive immunity. And then both of these offer protection from the infection. So when baby mom gets exposed to the COVID antigen, these immunoglobulins will bind to the antigen and protect from infection. I wanted to review immunoglobulins and where they come from and its key functions. So this image here is the respiratory epithelium. So the way to think about this is mother's body first. And I wanted to focus on IgAs here. If you turn your attention to here, so the way that IgAs are created, we have a dendritic cell and an antigen is exposed to the dendritic cell. And we have two pathways, either the T cell dependent versus a T cell independent. So the T cell dependent exposes the antigen to a B cell, and IgAs will be created from a plasma cell. So you have two IgA types, one specific to the antigen and one non-specific. The IgAs are then secreted through the respiratory epithelium via transcytosis and then mainly function in the mucociliary tract. So I have bulleted here. So secretory IgA is a polymer. So when it's secreted through the respiratory epithelium, it could be monomeric initially, and then it becomes dimeric. And then secondly, the systemic IgA, which is in the blood and serum, is usually monomeric. And the key difference is that because the secretory IgA is secreted across, it's non-specific and has broad reactivity versus systemic IgA, which battles more towards innate immunity. Secondly, I don't have a picture of IgGs, but IgGs directly neutralize viruses and antigens that pass through this epithelial barrier, and more specific mechanisms to trigger against foreign antigens. And then IgMs, lesser is known about how IgMs function, but we know that it contributes to mucosal immunity. Okay, so what we know is breast milk immunity to respiratory viruses not only arise from acquired infections, but there are pathogen-specific IgAs and IgGs. And so these rise in breast milk after vaccination and robustly are seen in COVID patients. We know that IgA levels in breast milk emerge very rapidly with the first 2 weeks after vaccination. They last longer compared to IgG levels. But it still remains unclear which of these IgGs, which of these immunoglobulins are important and are the most effective in neutralizing the antigens. So the objectives, is there a difference between overall antibody levels between groups who had COVID versus those who got the vaccine? What is the difference in the antibody subtype profile? And which antibodies contribute to the neutralization capacity? So my study cohort, we collected breast milk from a cohort of 60 people in those who had COVID during pregnancy and those who received both doses of the vaccine, and then at least one dose postpartum. So here's a table with the characteristics. So for the timeline, again, created the cohort, collected breast milk at delivery, and then 1 month, 2 month, and 3 month postpartum. And then we created serological assays of the antibodies, meaning to measure the amount of antibodies, we tagged it to a fluorescent antibody, and then it would light up when it shows us the amount of reactivity. We next measured the neutralization capacity, and then we did statistical analyses via nonlinear mixed effects curves, principal component analysis, and correlation matrices, which I'll show you in our result. Okay, so what we found was there are higher levels of systemic and secretory IgA in those who had COVID rather than vaccination. So if you look at this picture here, the systemic IgA is in red, and then the green is secretory IgA. So initially, we see that there's higher levels of systemic IgA, but over time, the secretory IgA increases relative to that systemic IgA. And then if you look at this group, this is all of the pregnancies who had COVID. Over all time points, they have higher levels of systemic and secretory IgA compared to the postpartum group, vaccine and postpartum vaccine groups. Next, we did see distinct antibody profiles in those that were COVID exposed versus vaccinated cohorts. So to look at this PCA plot, each point is a patient. When you look at the vectors, that shows the direction and strength related to that specific antibody. So if you have a longer vector, it shows a stronger correlation. And then the ellipses will show you the confidence interval between each groups. So most notably, we see that there's a significant overlap in the vaccination in pregnancy and postpartum groups. So that's green and blue. So we see that they're very similar in the antibody subtype profiles. The red is the COVID in pregnancy. And so we can see that because this is red and this vector is the IgGs and this vector is the IgAs, those are the primarily the subtypes that exist in the COVID exposed types. Okay, so the last thing we found was there is longevity of IgGs towards the COVID spike protein in breast milk following vaccination or COVID exposed groups. So again, you can see it here in both vaccinated and COVID exposed groups, the IgGs persist through 6 months postpartum. Okay, and so the other question was which immunoglobulins are important in the neutralization capacity. And so we know that it's associated with IgMs, IgG, and secretory IgA over systemic IgAs. The way to look at this is the correlation matrices. The green boxes just shows that we're looking at the association versus the wild type types of COVID antigens. And the darker blue means there's a stronger association with that specific antibody type. And so here we see that there's darker blue for the IgAs. So we know that there's a strong association between the IgA subtypes and the neutralization capacity for the COVID exposed pregnancies. But here there's lighter blue, meaning there's a weaker association with the IgA subtypes. So in summary, we know that there's high levels of systemic and secretory IgAs in breast milk in the COVID exposed groups. We know that the main contributors to neutralization capacity is the IgMs, IgGs, and secretory IgAs, more than the systemic IgAs. We know that there's a distinct profile in these antibody subtypes in COVID versus the vaccine groups. And so before this, or in thinking about why this is important, now we know the key contributors to neutralization capacity. We can really prove that there's a higher response to secretory IgA, and we can tailor our vaccine development to improving titers towards IgAs. Okay, so limitations to this project. It was a smaller sample size, especially in this COVID subgroup. A lot of people did fall into the vaccinated groups, and some patients in the COVID group also got vaccines. So potentially that may have skewed our analysis. We had some missing data, so we didn't adjust for time for exposure. But again, next steps, we would really want to see if current vaccines can induce more of an IgA response in people. And then we can always improve vaccines to induce this mucosal immune response. And I still need a thank you slide and acknowledgement slide, but that's the end.
Great work.
Well, with time.
No.
I
went way over. You're like 2 minutes over on time.
Very excited with your presentation, but I want that you come down.
Okay. Okay.
He's standing in a stool.
Okay.
Yeah, I think that's like one of the biggest points is this isn't like a walk around presentation. So if you need to point to things, it needs to be either you create an animation.
Standing still.
Okay.
Otherwise you're going to fall off the stool.
The mic is.
It's at a podium. There's a mic there. You can't move around.
You cannot move. So when you present, you need to use your mouse.
Okay.
And when you present also, you're going to say the graph on the right.
Yeah.
The graph on the left, or graph A, B, and C.
And what I like to do, because pointers can be finicky, is I will create an animation, an arrow will drop in to point that I'm pointing to this. And then I click and an arrow, or I put a box around something that appears and disappears.
Okay.
Most of your graphs have A, B, C or something.
Yeah, so but you won't be able to point to the screen. I think you can probably cut back on the introduction. It was,
But
yeah,
I
like.
think it's necessary for people who are not.
Yeah, I think you could, I like this slide. I think you could say it in less time. And then, because I do like the next slide where you talk about this you spend time on, and I thought that was great. The first slide I would spend a lot less time on, because it's just in general, how, that infant immunity comes from like transplacental transfer and breastfeeding, and with breast milk you get IgA, IgM, IgG. So that could be much less time.
You can just focus on one, like instead of saying the words and then pointing to the figure, you can just do it at the same time.
Yeah. Okay, cool.
And you can even, because none of this relates to the pregnancy aspect of it, right? Because we're looking at breast milk, you can even just take that part out.
Okay.
Just in your figure. It's good. And I think you spent time on this importantly, and I would just
keep that. Okay.
Yeah, just practice it so you're saying it more smoothly. And again, thinking about how you're going to talk about it without physically pointing onto the screen.
Okay. This one.
Are the two fonts supposed to be different?
Yeah, this is.
So I was wondering if you can cut some words to make the fonts the same number.
Yeah.
I just need to play. I just don't know which one.
Also, just make it into separate slides.
Different slide.
Because it is different information, right? Like this is what we know, and then the next is this is what we're doing.
Okay. I'm just writing this down. Okay. So 2 slides.
Yeah.
Okay.
And then the font will be bigger.
Yeah, you have 2 groups and you rush over the table.
Yeah.
Like, what happened?
Okay.
I agree. I think you need to just slow down, because that's the whole point, is your groups that you're comparing. So I would just.
Here are the results, but you have to say there are 3 groups and they were not significantly different in the demographics or something like that.
Okay.
I guess they're not
No
significant.
difference in age.
There was a difference in the race, but otherwise.
Okay.
And you can even say the majority of exposures were in the 2nd and 3rd trimester.
Something.
And like, that's an easy way to sum up sort of the key point here.
Okay. Trimesters. Okay.
And you may point out that the COVID in pregnancy is a small group, 8 cases.
Okay.
Mhm.
Maybe
compared
just
with
in
the other two.
general, like they have speaker notes.
Yeah.
So you don't have to like memorize.
I don't think they do.
Yeah, they do. Your notes will come up.
Okay.
Because they have
So
two,
you can
like,
read the script.
two screens, yeah.
Okay.
And then this one.
I like
This is
the
good.
timeline.
Yeah. And similarly, I don't think you need to say, you can just say, you know, you don't need to, because you're gonna talk about these statistical tests, you don't need to then say it, you know. I'm gonna say the cohorts were compared.
Here is when it comes, you need to be more descriptive, like this graph had actually 3 graphs.
Yeah,
On
exactly.
the right, the one in the left and the one in the middle, and you just point.
And say red is this, green is that.
You did perfect because I cannot read that.
Yeah.
So tiny.
And you can also make your own text box, overlay it to make it bigger, that IGA.
And you can write the whole script and basically read your script, so just keep you focused.
Mm-hmm.
Because,
It's like, yeah, under speaker notes, you just put it down.
Write out exactly what you want to say.
Can you like put a space in between the 2 bullet points?
Yeah.
More space, okay, more space.
I don't know if it's just me, but just in general, maybe the legends could be a little bit bigger.
Yeah.
you can make another graph.
You just make
and put it on
all
top.
on top, exactly. Make a text box on top.
All right, and then this one.
You did great on the graph explanation.
Yeah, this was
same. It's just be descriptive. You did great. It's just need to learn how to do it with the mouse.
Got it.
Yeah, so here again, you could have an arrow that points to, these are the green and blue, it overlaps, this is the red. And then and we can go through this separately, but a way to say it more quickly would be, you can see the red indicates difference in the distribution of antibodies by disease, and which is illustrated by the degree of the size of the vector, accurate. And you can see that it was largely driven by the presence of IgA and nucleocapsid.
And the legend also make it larger. I can help you with that.
Okay, larger legend, okay. All right.
Go back. Can you make the font a little bit larger?
Yeah.
I think you had a space to increase your font a little bit. That's it.
And then that second bullet point can be 2 separate. So significant overlap between vaccination and pregnancy and vaccination postpartum, new bullet point, and COVID-19.
Okay.
This one was fine. Again, just the legend, make that bigger. So it's IG,
Yeah, you have, I can see it, A, B, C. So when you're describing, you said in the A graph, A on your right, B on the middle, C on the left. So then you describe.
Okay. And this one. This one had a lot in there, so I just.
Good job.
Could make the graphics bigger and explain, because you are
Yeah.
explaining it, you know?
Yeah.
Do you need the wording in your graphs?
I was actually thinking, so like the top, I wonder if,
Can you make?
yeah, it's just like word, there's like a lot of wordiness going on
Make
here.
the graph larger and
Yeah.
Okay. Graph larger and
I guess you need the 3 graphs.
I
to
know you need
compare.
it to compare.
But do you need all the wording so you can make the graph the whole slide?
You need the wording for the piece, for the significance is the thing, because the image doesn't tell you what's significant or not.
Could you make like a chart or legend on the side and then have like
Let me
less
think. Yeah, we'll have to
words?
think about this.
I mean, it's not bad.
It's not, yeah.
It's not bad.
This is really small. I think just the spacing is a little off for the first 3 bullets.
Yeah, it's just hard to, it's one of those, like I said, like where people are gonna be trying to read the slide instead of listening to you. So we'll have to figure out how to, it probably needs to be split up into different slides, I
Maybe
think.
like almost like with animations, like.
I think the first 2 bullet points could be on one slide, and then the second 2 bullet points can be on another. Because the second 2 bullet points really connect to the image.
Yeah.
So we'll split that up into 2 slides. I think that way the image can be bigger and there's less text. Okay.
Just summary.
So in the summary of results, when you say we know, it sounds like this was previously known rather than what we found out. So I would say we found XYZ.
Okay.
And then I would just play with the font size.
Larger font, okay.
Go back to
Discussion.
So I feel like this is just too much text.
And the first two don't have a
Didn't we
period. at
say
the
that
end.
already?
Yeah, I feel.
Go back to the.
Yeah. Yeah, exactly. I think that I don't even think you need that next slide.
All right.
Yeah, I agree. So that's good. Make the font bigger. Get rid of that slide.
Maybe the last two sentences have periods and the other two don't.
Thank you.
And then the potential for improvement you talk about later. So I would get rid of that slide and then go to the next one. And this should be two different slides. One slide should be limitations and the next slide can be next steps.
Okay.
You know, most of the time you're there will be on these slides, but you kind of win or lose by the 5 minutes of questions time. So get prepared, you know, for many questions. And they're mostly clinicians, so probably not going to be too many vaccine makers. They're going to ask you, how am I going to make a more IgA, you know, whatever. There may be. Get ready for that as well. But I would imagine one question could be something like, in lieu of this data, you know, what would you recommend in terms of frequency of getting COVID vaccine? And especially in pregnancy, like, you know, there's a lot of controversy of, you know, you're at risk in COVID anytime, you know, but do you take it in the first trimester and then last a while? Do you wait like a Tdap and you do it later? Do it twice? Obviously, nobody knows the answer that I know of, but you're going to be up there. You're going to be
That's
at that point.
Because, you know, one thing is time, you know, people got it throughout pregnancy, but regardless, everyone, you know, there was persistence of immunity.
We don't want mom sick.
Yeah,
But at
you
the
don't
same
want
time, you want.
Yeah, so you can, yeah. So you could even put that in string so that people got it throughout pregnancy with persistence of immunity,
Yeah.
you know, regardless, you know, of timing of visit. The other thing is, you know, we didn't include it because it wasn't significant, but there was no significant neutralization against recent variants of interest. We dropped it for time, but this was the original vaccine and it really just produced immunity to wild type without significant immunity to the other.
You could always have.
So that could be like, we can just keep that as a like extra, yeah. Okay, great. We can keep working.
Well done, Mimi. Yeah.
He would love to, not, he can't do now. That he would love to try to do sometime in the next week if we have a lunchtime that we can.
Yeah, I think tomorrow's not gonna work, we're overbooked, you know, for patients.
Yeah. So
maybe-
maybe like mid next week, I'll send an email to you and I'll include Vince and Cindy and see if we can just figure out a lunchtime date. I told him that some of us still had time probably at noon, but he's scrubbing for cerclage.
Okay.
So
So do we have a meeting?
no, I sent an email basically being like, no, we like might run over and.
Okay.
Email or
Um,
at some point.
So he's gonna get an IgG
It's,
that day.
I'll work on it.
So we can see this, like.
Oh, yeah, because he hasn't had his echo.
Oh, you still have to have the echo.
Right, they're like treating it based on, like, rooms call them, and it can be based on like symptomatology.
Yeah, explore or, you know, the last thing I want is to be built. Recently had another paper.
No, I know.
So little.
that, Jefferson said they're gonna pay. Well, this one is too violent. I think last time I talked with
For the first like several days and then yesterday. This is not.
Is that the issue is that the Wiley contracts are renewed every year, they may not have renewed this. So they maybe they will,
So you just text me.
you know, next week. or
Yeah.
something. So there's many different, maybe the, you know, the fact that there's a medical student. Or something that's free. But we should
And I even agree now, I need to change.
Again?
Oh, great. I'm very touched that you well. Yeah, that's you too. Yeah, of course. So you got here this month?
Maybe we
or-
can read an email, we can do me.
Let's go, you just came, wow. Are you gonna be
You can-
at MFM?
Like, also,
Yeah, wonderful, yes.
maybe somebody can look.
Yeah.
Maybe, or maybe you, maybe the
Oh,
lead
yeah.
for communicating with Wiley and saying.
Oh, okay. Great. I'll be there.
I'm bringing a blanket because it's absolutely freezing in all the exam room. Like I literally packed a blanket, brought it to my office to have it tomorrow.
Just, it's a new world and we're all learning. At some point, if you need it
For segments.
more for future.
Yeah, it looks fine. It looks fine. Like, I mean, I'm done.
Attached to Rita
Like,
Library.
as much anatomy as I can, standing up.
Okay.
I haven't done a transactional on this, but I haven't, yeah.
For future papers, not
Okay.
send them to the journals. They will